Hi, everybody. Thanks for coming. Welcome to Straight, Sane, and Sober for July 26, 2022. It's a pleasure to be here with you. And today I'm honored to have Dr. Beverley Marais, who is a psychotherapist and a psychologist. And she's an expert in eating disorders and addictions. So she's been working in the field for how long, Dr. Beverley?
Oh, I think probably about 16, 17 years.
Oh, okay. Well, great. So
Yeah.
we'll get this show started, and thank you for joining us. So let me. This is always trouble, Hi, I repeated it. I never get that right, Dr. Beverly. But so welcome, and as a tradition with this show, as a poetic warrior, I always read one of my poems, and this one is called from my first book, The Seraphim on the Cusp of Spring, which is my first book I published with Amazon, and this is basically a purely romantic love poem that I wrote called Truly Simple is Simply True, and it goes like this. I love you, like the diamond the light it refracts. I adore you, like the infant the comfort of a first teddy bear. I cherish you, like the morning glory the sun that lets it bloom. I treasure you, like the hidden riches within the depths of the planet. I want you, like the air currents upon which winging swallows soar. I need you, like the oxygen that keeps alive every breathing creature. I desire you, like the delicious tastes of a peach in perfect season. I crave you, like the fields of wheat, the fertile soil from which they grow. I trust you, like the innocent child, the wisdom of a deeply devoted parent. And I respect you, like the great judge, the integrity of the correct rule of law, because every morning I wake from a night of scattered dreams to open my eyes once again to the sweet, sublime beauty of reality, in which the gift of your fine presence fills me with longing to hold you through the trials of doubt to which I am subject, living a life where the actuality of the Lord is in question. So pick it up at Amazon if you want. It's under D.E. Walsh. And so, welcome, Dr. Beverly. How are you today?
I'm really good, thank you. I was actually really interested in your poem. So Dale, is that something that you composed?
Yeah, I've been writing poetry since I graduated from college in 1985. I have an archive of approximately 5,000 works.
Wow. And was that inspired by anything or anyone?
Well, I always have my muses. I'm not sure exactly which muse I was referring to, but my life has been a constant rotation of new muses. But yeah, I can't remember who it was written for. But that's the beauty of the poetry is that ultimately, it goes beyond the person that inspired it to like hopefully reach some sort of like general or universal audience.
Yes, and depending on where you're at, you could be reading, or who you are, you could be reading all sorts of different things and making all sorts of different interpretations, really,
Right.
of it.
Well,
Because,
actually, I
because
think that poem was written back in like 2014.
okay, just listening to you on it, I was thinking actually that could refer to a romantic partner, It could also refer to an addiction. It can refer to eating issues, a relationship really that you're sort of absorbed in
Right.
some way. Hmm.
Well, it does have a certain obsessive quality to it.
Yeah.
But well, thank you. Yeah, as I say, I wrote 6 books before I graduated from college, and then when I graduated from college, I decided I was going to turn my focus to poetry, and I've been doing that ever since. So, 5,000 poems sounds like a lot, and I guess it is to a degree. But basically, I've been writing at least 100 to 200 poems every year since 1985, so it accumulates.
Wow, that's certainly consistent.
Yeah. Well,
Yeah.
actually in 2017 I only wrote 67 poems, and I thought I called that was like the low point in my production. But so on January, my resolution for 2018 was to write a poem a day, and I did that for the next year and a half. So I sort of caught up with my quota.
Yes. Okay. No, that's impressive.
Well, thank you. And
Hmm.
I guess poetry as I do it sort of is an addiction, because people ask me whether I do poetry for therapy and everything, and I always was like reluctant to say I was doing it as therapy, but it has been like a great outlet and a great release for me and my mental health journey.
I absolutely, and I so appreciate that because it's a creative outlet, and it's one of those things that can really completely absorb you, like any creative any sort of creative pursuit, art, for example, or drum or music. It's one of those things that can be really therapeutic for people.
Right. Well, I I never even used it, consciously as therapy, but of course, like just getting your feelings down and and expressing yourself is like key to recovery. I think from anything, whether it's schizophrenia or drugs or substances or eating disorders, if you can like have the insight to just like get something down. I mean, it doesn't have to be like great art, but just like to be able to journal or to to be able to express yourself, I feel is like a very important part of recovery.
I agree. I think, on the one hand, there's certain things that can distract you, which might be really therapeutic, like for example, poetry or reading or art or music, that really sort of shifts your attention and takes you somewhere else for a period of time. But then there's also the other things that you've just mentioned, really having that awareness of your thoughts and feelings and behaviors and what really goes on for you, what motivates you, what your triggers might be. And it's, for a lot of people that journal, they do tend to have that level of, what's it, that increased level of awareness really to what goes on for them. And
Right,
and that then helps them change some of their behaviors versus because part of what happens with journaling is it helps you make the unconscious conscious, and when we're conscious of what we're doing we can then make changes. Otherwise we're really just driven by unconscious needs and desires perhaps.
well, Bob Proctor calls them paradigms. That I don't know if you know who Bob Proctor was, but he was like what he was like. He died this year, I think, or early late last year. But he was like totally, totally into like self transformation and everything. And he always talked about paradigms. I always like laugh when he talks about paradigms because he's like so adamant about how you got to change your paradigms. But I think that's another thing that's very important is that people have to realize that 95% of their behavior is habitual behavior that's just like programmed in, from an early age. And you have to be aware of that programming, and in order to like recover or to improve or self-develop, it's very important to be aware of the paradigms that are driving you, so that you can change them, because I think paradigms tend to be like very negative instead of positive. So, if all your thoughts and processes are like being negative, then you're never going to be able to get out of the rut you're in.
Yeah, and I think different models and different theories would use different definitions and different types of language really around it. So you might have some. I was wondering if I was hearing a buzzing or something. Um, but some models like CBT would be referring to our beliefs,
Right,
and these are the things that then which might be similar to what Bob Proctor is referring to as paradigms. I don't know, but it's the things that we sort of learn about ourselves that we sort of take on board early on in terms of our early experiences, our nurturing environments, really that we're exposed to, and this then can lead us to develop our identity, our belief systems really about ourselves that then informs our behaviors,
right,
which you might be referring to as programming, really, in a way. And it's about having that awareness, that understanding, the making sense of what these thoughts, belief systems, feelings are, what the behaviors are that we might be engaging in on a regular basis that are helpful, and those aren't necessarily so helpful. To try to try to sort of promote successful outcomes.
right. Well, this does dovetail right into what our topic of discussion is today, which is addiction and eating disorders. But because having had my own experiences with addiction, I was like basically a pothead for like 35 years, and a beeraholic for the same amount, maybe a little more, but you know, but you just get into the habit. I mean, I think that's how most addictions begin, is you just get into a habit of, and it makes you feel better at the moment, but then the effect wears off, and you're craving the comfort of the self medication, and that's how addiction builds, so far as I can see.
Yeah, I think absolutely. I think it might start off as a result of something, as a result of perhaps early pain or even trauma that might have been going on. So you might be using maybe drugs or substances to self-medicate, really in some way, but then it becomes a way of life in a
Right,
sense. It then becomes, as you said, a habit, and you then begin to associate certain things, or the brain associates certain things with the drug or the substance really of choice. So going to a certain place, there's a part of the brain that's lighting up perhaps, and a craving then emerges, and then you'll automatically find yourself going to get the drink or the drug or whatever.
right. Well,
Mm.
there's a chemical component too of like releasing dopamine. I mean, people talk about how cell phones are so addictive, and it's just like those little pings that you get to let you know that a message has come in. I mean, Stephen Jobs, when he designed the iPhone, knew it was going to be addictive, and because every time you hear a ping, you get a little dopamine hit, and dopamine is like the feel good, chemical in the brain. And
Mm-hmm.
I don't know if you knew this, but Stephen Jobs wouldn't let his kids have iPhones.
Yeah, yeah. Mm.
But
Yeah, I think the thing with social media, it's really designed to hold our attention um, all of the time. So and again, it becomes a habit. It's the thing that is really easy and so convenient to reach for, to forget about certain things, to pass the time, to manage boredom, and to sort of, I don't know, make things happen, even really in some way. So it becomes a really easy solution of sorts, but ultimately isn't necessarily so helpful for many people.
well, so dopamine and serotonin and all the brain chemicals that are released with addictions, how, do you go into, have you like studied that extensively? You must have in the course of your education because it seems to me
Yeah,
that's like so foundational to addiction.
yeah, I think way back, I did do a lot of work on what happens really with the brain in terms of addiction. I couldn't actually recall a lot of that on hand right now. But I guess whether it's food or a drug or something, there are always going to be chemical reactions that go on really in the brain, in the body, in response to what we're doing and our behaviors, because we're constantly conditioning ourselves to feel good about certain things or to seek pleasure of sorts. And if there's certain behaviors that provide that, it then can we can become dependent on it, whether it's sort of a physiological dependency or more of a psychological dependency, really, in a way.
Well, one thing that I've often wondered, Dr. Beverly, is to what degree is any addiction or any habit really psychological? Because I feel it's all physiological because the addiction like changes the chemistry of your brain, and even though you might not like feel physically addicted, I mean this is what people say about marijuana for years. It was psychologically addictive, but I think that just the transformation or the change in the brain that the drugs or substances cause is like in fact a physiological creates a physiological addiction because the brain starts to crave those substances rather than the body itself, but the brain. When people say psychological addiction, they don't realize that the brain is being transformed and changed in form by the substances.
Yeah, I think that traditionally the definition partly of addiction or dependency on substances has more been around what the ability to withdraw from them, to have sort of actual physiological symptoms, withdrawal symptoms from a substance that tells us, oh, there is a physiological dependency really that's going on. And I think a lot of the research with cannabis or marijuana, is has been it doesn't provide that physiological addictive response, but it's been thought to be more psychologically addictive, and that might be absolutely because of the changes that you feel
Right.
when you use the substances. It's something that makes you feel good in a way. I guess I'm just thinking about it, say sometimes with food sometimes, and there's also that debate that some people have, whether are certain foods more addictive really than others. And there's been perhaps a lot of research, perhaps by the food industry, that tells us that they're not addictive, that sugar isn't necessarily addictive, but perhaps there might be certain chemicals in there that respond in different ways to different people. That so say with food, for example, people might be more sort of associating pleasure really from certain foods and wanting to feel good a lot of the time, or comforted really in some way, in a similar way that some people might find with a drug or alcohol, to seek
Right.
pleasure or comfort or to feel safe or to manage all sorts of emotions. And what you referred to earlier is as a way of sort of self-medicating whatever else is going on. And I know for working in mental health, a lot of patients sometimes have used things like cannabis to help self-medicate for some of the symptoms that they experience for various mental health problems, whether it's high anxiety or schizophrenia, for example. So there's it's quite complex, and I guess people's motivations can be very different depending on their individual needs.
Well, that's in my own case. I use marijuana, and I think I told you this yesterday, but when we were talking, but basically I was addicted to marijuana. I was really truly addicted to marijuana for like 35 years, but the thing is, I would rationalize my use. I mean, everybody would tell me it was the worst thing I could do for myself, and it was like it was an obstacle to my mental recovery and everything. But I just couldn't give it up, and I was very stubborn about it. I mean, my doctor, like, he called marijuana my nemesis, and my mother hated it, and she blamed my whole mental illness on marijuana, and you know, but but I just felt that I knew what I needed, and I needed marijuana because I needed it as a side effect medication for the chemical edge of the antipsychotics I was on, because without something to temper I call it the chemical edge of antipsychotics. I would just like be totally distracted and jumpy and out of phase with my body. And so, uh, but then when I did give up marijuana and beer at the same time, it turned out that what everybody had been telling me was true. It was just a rationalization because I was too stubborn to want to try to give up. But it was also like it was. I mean, I gave it up cold turkey one day. I just like walked into my bar after a visit to my mother's birthday, and I sat down and I said, my mother hates my partying so much. I'm just going to give up everything. So instead of ordering my first beer in a week, I ordered a Coke, and I haven't looked back. I never like joined a AA program or any type of like 12-step program or anything, uh,
Mm.
but uh, but that addiction, basically I just outgrew it. And I don't know, a lot of people, I don't think have the time to be able to outgrow it because it kills them before they can outgrow it.
Yeah, I think, and that's certainly something I experienced working in sort of inpatient units and community settings as well. Is that sometimes people are having to go through these cycles several times until they're ready at some point to change. Yeah, and ultimately, we know that motivation to change has to come from the individual in some way. Sometimes it helps if other people are, enough of a motivation, but at some point there has to be that shift where they sort of take on that responsibility and accountability around change, and that's often where it becomes the most successful for people. But you're right, sometimes for a lot of people it can take years, and for some people, unfortunately, they almost are having to lose everything really before they are able to recognize some of the dangers or and I know, as just even seeing that, I'm also conscious that some people have very difficult lives and very difficult experiences and use substances to help manage, to help them survive really in some way or other. So it can be quite complicated, really, the whole motivation to recover.
Right, right. Well, this we were talking about food addictions too, and tell me if I was misinformed, but basically I heard that sugar is more addictive than cocaine, and that's how like the big companies like get everybody to eat this stuff that's really like non-nutrition, and I'm
Mhm.
guilty of that too. I mean I eat it much better than I used to, but this idea that that sugar is like so addictive. I mean, I know this isn't like an eating disorder or something. It's just like a problem with general population. But just like the way our food is marketed and like distributed, it's like it's an addiction in itself, and it's even worse because you can't do without food.
Yeah, and like I said earlier, there's that debate as to whether certain foods might have a physiological addictive quality to it or not. There hasn't necessarily been any evidence really around that. But certainly in terms of people's behavior, we often think about it as more of a psychological, sometimes dependency, really on say certain things that make the brain sort of light up a little bit and feel
Right.
good. And so in order to feel good, people then might then want more and more and more of something that tastes very nice, and overriding whether they are hungry, whether they're full. They're just sort of motivated by the pleasure of whatever
Right.
it is that they're eating.
Well, that's sort of similar to cocaine too. I mean, in my experience, people, they do more cocaine than they ever need just because, they get that first hit and it's like tremendous, and then they're just chasing that first hit feeling for the rest of until it runs out, and then they go out and buy more because they're still after that first rush.
Yes, and with cocaine and heroin per se, that first feeling is, a lot of people then tend to describe as so wonderful and so amazing that they every other time they're sort of looking for that same hit, and
Right.
and they're having to increase what they're having in order to have something similar. So their tolerance gradually increases then over time. They're having to use more and more and more really to feel good. Um, but ultimately, what then happens over time is all of the negative, the longer term consequences really around that, because you're spending a lot of time using substances to regulate your emotional, physiological well-being and needs, and then never really learning how to skill yourself, how to do that without a drug or substance.
Well, the other thing about escalating need is if you get clean and then you go back to your old level, it can be very dangerous. I mean, my sister lost her husband that way. He was a heroin addict, and he got clean for about 6 months, and then he broke down. And guess he had some extra money, so he went out and got his heroin, and he got the same dosage that he'd been on 6 months before, which is which was like a high dosage, and he did it, and he got my sister walked in and he was dead.
Yeah, that's so sad, and I think that that's one of the things that within a lot of treatment programs they talk about quite a lot. That it's about people being really careful if they do have lapses along the way, because the dosage is that they're not going to be able to tolerate what they had before. It's
Right.
very, very dangerous. Yeah.
And this question just get. Oh, first off, let me just take a minute to say, hey everybody, it's the second anniversary of the Mental Health Warriors today. So send in your comments and congratulate Adam and Carrie and the whole team. And we've been around for 2 years now, and we're just getting started. But just wanted to throw that in while I was thinking about it. But help us celebrate. Tune in, turn your friends on to Mental Health Warrior TV because it's one of the best enterprises out there. And stop the stigma and never quit. But now getting back to you, Dr. Beverly, I one question that just popped into my head was this controversy about methadone. I mean, I've heard a lot of things about methadone. I mean, obviously, I've never done it, but because I never had it. But ha, what do you think of like substituting like something like methadone for which apparently is almost as addictive as heroin itself to solve the heroin problem?
Well, I think in treatment programs, what they tend to do is when you think about going out and buying heroin, you're not really sure what. I guess people aren't really sure what they're getting exactly, and this is why it can be quite dangerous. Whereas with methadone, it's controlled in some way, and if you're having it as part of your treatment program, generally people would the treatment team would be titrating it. So gradually people would be exposed to a stepped, a staged
Right.
sort of reduction over a period of time in whatever way it needs to be paced for individuals. But that would ultimately be the goal, is to gradually reduce the dependency really on it while they're sort of learning how to manage the emotions or their life circumstances really in other ways.
So that brings up another point is, this seems to be like a dilemma. I'm really not trying to give you a hard time, Dr. Bev. I'm just like thinking about like questions as you're talking, but
Mm,
this idea that, modern medicine, I mean, we have all, there's a medication for everything, and, you watch these television commercials. I don't know if it's true in England, but in America, like apparently like 30% of all advertising on TV is drugs for like various ailments and everything. But so how do you feel about like the state of the medical field, and that it treats symptoms, it doesn't treat the cure, it doesn't cure the cause. I mean that's what I think is really like crucial because go on.
yeah, no, I was just thinking a lot of patients and clients are also um, a little bit nervous about medications and stuff as well. And as you say, not necessarily treating the cause, just managing the symptoms. And there's I mean, for all of these things, there are always extremities really in life in terms of how people approach it. But the ideal thing is it's always dependent on a case by case basis. So for some people who maybe are struggling with anxieties or depression and everything, the ideal first step really for treatment would be some form of psychotherapy of sorts. However, if they're really struggling to function psychotherapeutically and use therapy in some way, sometimes it's really helpful for them to have discussions really with their general practitioners or doctors in order to see whether medication might be able to help. And it's then using medication in conjunction with psychotherapy to what the medication helps them stabilize some of the mood, some symptomatology, or some of the symptoms that are going on in
Right.
order to build skills that they're needing to cope and manage their lives or regulate their emotions a lot better. But it's not, it's, medication isn't the be all and end all. It doesn't really work for everyone. So it's something that is always approached with caution, ideally.
Right. Well, my own experience is a little different because even though I was a marijuana and beer addict, I always said that schizophrenia is my real problem. Substance abuse isn't
Mm,
my problem. So, but what I was thinking is that uh, with mental health, with mental illness questions, it's like a little more it's a little different because you know people the medical model of mental illness at this point. I think this is changing, but for like 50 to 100 years, the idea of mental illness is that there's a chemical imbalance in your brain. I mean, this was like always hammered home to me in all my therapy and everything. There's
mhm,
nothing you need the medication to regulate the chemicals in your brain and everything. But
mm,
now I'm very grateful for my medication. I mean, I feel that if I hadn't had my medication, I would have been like backward a long time ago permanently. So I'm very grateful to the medication. But it's just like this idea that mental illness is caused by chemical imbalance in the brain. My first doctor, I used to in the hospital after I was initially hospitalized. I've told this story a lot, but he said, I say, why am I in here? And he goes, well, if you broke your leg, you'd come to the hospital, right, Dale? I said, yes. And he said, well, you broke your brain, and so whether it's from drugs or whatever, he basically said that my brain was broken, and not only is that proved not to be true, but it's also something that I self stigmatize myself with for 35 years. Just believing that I couldn't like break out of the limits caused by my broken brain. and that's really something that I think has to be addressed when it comes to psychological and mental illness. I mean, and probably in addiction and eating disorders too, because those are basically mental illnesses too. But it just seems that this idea that the brain can heal itself, I mean, it's coming much more into focus with the recent research and everything. But, I think that for a long time, all mental illness was seen as a problem with the brain, whereas there's so many factors that can cause like a psychotic break that to isolate it to something in the brain, I think, is rather short-sighted.
Yeah, I think absolutely. I think there are so many factors that can really contribute to mental health. There's all sorts of genetic um, components that can contribute, as well as environmental circumstances and stuff that might be contributing. So so yes, it's I think all sorts of medication is, and practitioners would generally be quite cautious in terms of thinking about what firstly the diagnosis is, and then what the recommended treatment is for it. And there's certain mental health conditions where absolutely medication is the thing that will help improve someone's quality of life quite considerably.
Well, I don't know what the state of psychological medicine in England, but at this point, you were talking about getting therapy and psychotherapy and CBT and is the CBT cognitive behavioral therapy. So, but the system is so overwhelmed, especially since COVID, that like doctors, I mean, no matter how much they want to, they just don't have the time or the bandwidth to be able to treat patients on an individual level because they're seeing like 50 to 100 patients a week, and
Mm.
so medication has become the go-to answer. But you know, but I was very fortunate in that I had like extensive psychotherapy in addition to the medication and everything, and I still went to the hospital 15 times. But just but this idea that the people need like therapy, but they can't get it because the overwhelm of doctors and social workers and psychological workers, the work overload is so great that it's like impossible for them to get people the treatment they need.
Yeah, I think
Yeah,
that's absolutely. I think it's really sad, and I think that the medical system, the services have been oversubscribed, really overwhelmed since COVID, during and post COVID, really because of the increase in mental health conditions, often as a result of that. And it's meant that resources here in the UK really have become very limited, and even for people, to have treatment, say, whether I don't know so much about waiting lists and stuff really for addiction type treatment, but certainly for eating disorders at the moment, there are sort of long waiting lists, and the criteria for people to receive treatment is very limited. And so people then struggle, or people are then on long waiting lists, and some people might be deteriorating while on waiting lists as well. So it's not really great at the moment.
right. Well, I don't know if we got off the topic a little bit, but could you just enlighten us a bit about eating disorders? I mean, I know that there's a bulimia and anorexia and binge eating and stuff, but could you just like tell the audience, some like basic facts about eating disorders because I think it's becoming more and more a problem, and I mean, there's a obesity epidemic in the United States, and that's partly that the quality of the food that people are eating. It's also like I think it comes under the the heading of eating disorders a lot of times, even though people don't want to admit it.
Yeah. So in in terms of just even different categories of eating disorders, there's what you've already mentioned. There's anorexia, where people are restricting what they're eating quite a lot, and very often are losing a lot of weight. Um, but it's not necessarily, for some people can be anorexic without necessarily losing a lot of weight. It's more about the behaviors that are involved, say, with food. However, for those people that are losing quite a lot of weight, there's a lot of risk factors then involved, in terms of abnormalities really with their blood results, their the heart functioning, all sorts of physiological things, blood sugar levels, everything becomes compromised. But also, the longer that they're struggling with anorexia, the more the brain becomes starved, and the more the anorexia really takes hold over time. So very often we're sort of wanting to get people into treatment as soon as possible in order for them to have a much more positive prognosis at the end of that. And then bulimia generally is when people might be going through a process of restricting as well as purging in some way. And purging can be either vomiting or over-exercising, or both of them. But what they're always doing is they're restricting, and then they're binging, and then they're purging in some way. So they're always finding some way of compensating for the amount of food that they're eating. And
Right.
and it's just a cycle that goes round and round and round really all the time. And at some point people come into treatment because either they are actually quite ill, as a result of vomiting so much, the impact on their teeth really can become expensive, noticeable, painful a lot of the times. So sometimes for physical reasons, but also for social reasons, feeling like they're becoming more withdrawn or not socializing as much, or that the bulimia is sort of taking over their lives in some way and they've lost control. And then with binge eating, it's very often when people are eating either large amounts of food in one go, a lot of the time, or they start eating and they're just continuing really, throughout the day or in the evenings and everything. But binge eating disorder is when people are doing all of that, but they're not compensating for what they're eating. So they're not vomiting or purging or anything. And what sometimes happens for people, which they can find really distressing, is they lose control over their weight, their bodies and stuff, and it can cause some physical health issues and problems as well. And one of the tenets with all of these eating disorders is that sometimes it can start as a way of wanting to feel in control of something or to manage something or other, whether it's feelings or emotions or body image in some way. But over time, it ends up when people are being controlled by the eating disorder and feeling out of control ultimately. And then, of course, there's another sort of bracket, which is sort of eating disorders that, or feeding and other eating disorders, which really covers all sorts of eating disorders. Things that don't fit neatly into the categories or brackets of anorexia or bulimia or binge eating disorder or others. But they would have features of some of them, and a lot of people fall into that bracket as well.
Right. So, to what degree? To what degree? Well, actually, let me get to the bottom line. So, what do you do to? What treatment is there for eating disorders? I meant
Sorry,
because
say that again. I missed that, Dale. Can you say that again?
I said, what treatments? I mean, what treatments are there for the eating disorders? I meant, it's like
Yeah.
mm,
So so
because
so there's, yeah, so we have sort of the we have sort of clinical guidelines that have sort of set protocols that are recommended, say, for different treatments. And with young people, it's generally sort of family-based treatments or family therapy, or a lot of nutritional therapy, really, for them, because they at quite a high risk. Their bodies are growing and developing and everything, and there could be all sorts of changes that happen that can put them at risk. So there's that, and then for adults, there are things like cognitive behavioral type therapy. So for anorexia, there's interpersonal type of therapies for anorexia as well. And similarly, say for bulimia, there's group treatment for bulimia that's also found to have been very helpful. There's cognitive behavioral therapy for bulimia that also has a high evidence base, really, for that. And then for binge eating, there's also a lot of cognitive behavioral therapy and treatments, as well as psychodynamic treatments that are helpful. But for each case, what a psychologist tends to do is build a formulation with the client to understand what are the factors that are involved, what's maintaining the problems, what's keeping all of this going, and then using the protocol, really, for whether it's anorexia or bulimia or binge eating, seeing what are the areas that they're wanting, and also what level of risk is going on for the person, what they're needing to focus on, really, initially. But food and nutrition is always a big part of treatment.
Okay. And so, is there like a dietitian that people can? I mean, do you bring in
Yes,
dietitians?
yes. So absolutely, very often, depending on what's going on with people, it's not just one therapist that's involved. It's sometimes a team of people. So you would have maybe a psychologist or psychotherapist. You'd have maybe a dietitian that focuses on the nutritional element and maybe sort of generating meal plans and psychoeducation around what goes on in the body when people are introducing proteins and fats and carbohydrates, etc. And also managing if some people are needing to gain weight in order for their bodies to function in the best way, what the process and the procedures are really around that. If people have been starved almost for a long time, there's again specific procedures that dietitians and medics would be involved in to help refeed them in a safe way, so that to lessen any risk of physiological complications that might occur. There's the GP that's involved in many cases, especially when patients are needing blood tests on a regular basis, and or bone scans as and when, particularly if they're starved, they're not sort of eating enough, they're sort of their body's malnourished, really, in some way. And what else? So those would be sort of the key people involved. There might be a psychiatrist involved, depending again on complexity that's going on. But that sort of forms, this is the team essentially, really, for many people.
Wow. Well, so you're into both eating disorders and addiction. So, how do you bridge? What's the bridge between the two?
Well, I started off initially working in addictions, and my interest there was really around how, what goes, just really how to make sense of why people might choose to engage in certain behaviors that aren't necessarily so good for them. What's going on? And I think I was really interested in how people attach their attachment relationship, how people attach to a drug. What is it that they're getting from that? What needs are being met really in that way? And then thinking about, so then how do we work with change? How do you help someone change and disengage from one object and look at all sorts of other things that are going on in life and life goals and stuff, and get back on track in a way. And and looking at the fluctuating motivation levels really for people. And when I then started working with eating disorders, there were really a lot of similarities really within that around motivation to change, which is one of the big, one of the features, say with addiction, is that keep people going in and out of treatment is what is their motivation to change? Have they made a decision to change? And even if they have, though, there's often a lot of ambivalence going on. A part of them wants to, a part of them doesn't, and then it's really easy to lapse a lot of the time or relapse. And similarly with eating disorders, people might be coming into treatment wanting to regain control again of their lives, their bodies, food, eating, relationships. But the challenge is it can feel very scary. It means having to face and confront uncomfortable feelings, uncertainties, and not knowing necessarily how they would be coping, and not immediately reaching for a drug or food or restriction in some way really to cope. So there are those similarities really around changing behaviors that can make, so say with addiction, it's someone being attached to a drug or a substance that gives them comfort or support or helps shut out things in some way, or regulate feelings or manage other symptoms and stuff. And with an eating disorder, very similar. So for a lot of people, it sort of helps them feel in control in some way, or helps them feel safe or special even, or different, or comforted, or helps them shut down or manage uncomfortable emotions and stuff. So there are quite a few similarities really with that. And ultimately, for a lot of people, these might be similar things that a lot of people ultimately end up sort of end up being challenged by, how to deal with their emotions and ups and downs and life circumstances and feeling in control. But some might use a drug or substance, some might focus on eating, some might be engaging in stuff in relationships. There might be all sorts of gambling, even there might be all sorts of ways of managing and trying to regulate
Right.
emotions.
Well, I know what you're talking about making a decision, because I think that's like crucial to the whole process. Is because before I actually stopped, I was like vacillating with my beer and my beer problem more than my marijuana problem, because I never thought I'd give up marijuana, but I
Hmm.
did. But I remember like there would be times when I would say, okay, I'm going to give up alcohol, and then I would go up to the bar and say, I can't give up alcohol, because if I come into the bar, and I'm not drinking, and they know I'm sober, then they're not going to like serve me if I want to have a beer. So I hadn't like committed to the decision completely. But once I did commit to the decision, and I said I'm going to give this up for my mother, then I did it with an iron will. But I think that point of no return, of making that decision, is like one of the scariest things there is about like dealing with addiction and even the eating disorders.
Yeah, I think so, and certainly what you're saying is you reached a point after several attempts, perhaps, and also you hadn't quite decided that you wanted to give up. It was, or if you had, it would have been maybe a temporary thing, until there was a certain point when that worked for you and you made that decision, and things then started to change. And I think a lot of people perhaps maybe sometimes wait for that moment of clarity and think, oh, there's going to be a light bulb moment or an aha moment, that's going to make them sort of see the sense in all of this and everything will change. But actually, that doesn't off that doesn't happen very often. People don't generally spontaneously get to that stage. Sometimes there's a lot of the motivational work that's involved in helping people recognize or helping people confront really their current reality and what's really going on, versus what very often happens is being stuck in denial in a way, and telling you, and as you said earlier, rationalizing the
Right.
reason why you're doing what you're doing and finding your way of making sense of it, when actually that's not really what's happening in reality.
Well, that makes me think of something I heard at my convention recently. Is that if you make an excuse, then no matter how justified it is, it's still an excuse. And that's like the type of insight you have to see where you're saying this is a rationalization, this is an excuse, but it's not justified, it's not valid. So, that's basically the point I arrived at, and that's what gave me the strength to like just go cold turkey and and do it myself. But it was also the Lord. I meant I think I told you about my cigarettes, how I gave that up. One night I had two left, and I said, "Oh, I'll have one now. If I don't have this last one in the morning, I'll be able to quit after 38 years of pack a day of Marlboros." And that's what happened. But I had like no cold turkey, no withdrawal symptoms or anything. But sometimes you just have to like put yourself in the hands of the Lord and say, that this is what's going to happen, and just trust in your own decision and in your own faith.
Yeah, and I think one of the treatments I didn't mention earlier is that, particularly in addictions, that people use sometimes is the 12-step program,
Right.
where they, it's in a similar to what you just mentioned, where they do talk about a higher power of whatever. It can be spirituality, it can be religious, or it can be something else, unique to the individual, but something sort of bigger than them in a way of as a way of encouraging change and insight.
Well, we're almost at our time, Dr. Beverly. But I want to thank you very much. This has been very enlightening, full of insights. I hope for not only me but also my audience, our audience. And thank you very much for joining us. And so I also want to give a shout out to Robert Brooker, who shows up on my show every week and is always busy in the comments and setting the comments on fire. But so we have about 3 minutes left. So first off, is there any way that people can contact you, or if I don't know whether you're like hired out by the NIH, but is there some way to contact you to
Yeah,
follow up?
so yeah, no, thank you. First of all, thank you so much for having me here, Dale. It's been really fun talking to you about all of this, and I know a lot of this is quite serious as well. So I really appreciate being able to share something that might be of help, really, to someone or other. But in terms of contacting me, people can contact me through the Mental Health Warriors, really, as well. But I also have um, a service which is the eating disorder psychologist. And so it's the eatingdisorderpsychologist.com. And on that service, on the website, there's various ways of sort of contacting, emailing in, or booking a free consultation if people are just unsure where they're at, or whether they're needing sort of help or treatment and stuff, or which way to go really around it. I'm really happy to help with all of that.
Well, thank you very much, Dr. Beverly. This has been Dr. Beverly Marais, and just thank you very much. And I hope everybody enjoyed themselves and got some valuable insights into not only the eating disorders and addictions, but also just into their own mental health and how that's trending. And thank you very much. And let me just get this last little. Uh, last little video going. And thank you very much, everybody.